Hi everyone, just wanted to do a short summary of our material from last week. Putting this up a bit early. I'm actually traveling out of town tomorrow and just wanted to make sure that you had your summary up for Monday. I will be out of town throughout the week, Monday through Friday this week, so I will not be in the office in Pittsburgh, but I will be available via email. You can call the office in Pittsburgh or you can reach me at the text number that's in the syllabus. I will likely not be available during daytime hours though. I'll be available early in the morning or late at night. That's when I'll be checking my emails. If you do text me, if you email me, and you need something in emergency, Dr. Wentling, who is our department head, can help you out in an emergency situation if there's some type of academic emergency that you need assistance with. But otherwise, I'll get back to you within 24 hours. It shouldn't be too long before I get back to you. So I just did want to go over a little bit from our work this past week. Talked a little bit more in detail about Medicare and Medicaid. And if you do have any specific questions on any of the content from this week, please let me know. But I did want to touch a little bit upon the discussion because I think that our discussion was a bit tainted from our work over the last couple of weeks. So in thinking about our discussion, obviously we were thinking of ourselves as the CEO of Kind Heart Hospital, our fictitious hospital, in a low-income area. Been spending a lot of money over the last many years on charity care, but we're currently in a bit of a tough financial spot because our reimbursements, both through governmental payers and our commercial payers, are declining. So we're looking to see how we can continue to provide quality care to both our paying patients, but also our mission-based patients. So those folks that need access to care but can't necessarily pay for that. So we want to continue to be able to provide that care. So in thinking about that, and lots of people had really great ideas about cutting costs in different ways, decreasing salary, and other ways to provide care, through different ways, to provide volunteer care, cut supply costs, etc. But the thing to keep in mind, and this is where I think that our thoughts are a bit tainted, because we think about, especially for those of you that live in the general greater Pittsburgh area, we think about the large system here. So large systems here, UPMC, AHN, which are more wealthy systems, and our discussions that we've been having over the last couple of weeks. So, cutting salaries, the exorbitant salaries and exorbitant expenses like private chefs and private planes and those kinds of things. But when you think about a hospital like our fictitious one here, Kind Heart Hospital, this is likely more representative of the majority of hospitals in the country that are just small community hospitals, not part of really large systems, and are likely running closer to the margin, meaning zero profit, zero loss, or even in the red, meaning that they're running at a loss. That's really what most hospitals, unfortunately, in this country are doing. They're not making $1 billion profit each year. So they don't have exorbitant expenses to be cut. So when you think about what can hospitals do to cut costs when they don't have those easy picking things like, oh, well, the CEO can take $1 million cut in his salary, or the COO can take $100,000 or $200,000 cut in their salary, then what can they take? Well, that's when you look at, well, where is the fat in their budget? And there's always fat in a budget. So where is the fat in their budget? Well, maybe they can take a 10% cut across the board in salaries and administrative salaries, because they likely are being paid quite well. So where can they take those cuts? Or you can look at supply costs. A great place to cut supply costs are in OR supplies. Oftentimes, physicians get used to using specific supplies in the OR that aren't necessarily the most cost effective, but the cheaper supplies often work just as well. So is there a way to cut supplies there? Cut supply cost. Also, just-in-time ordering across the enterprise? Are we ordering supplies or drugs or different things across the enterprise, and then having wastage because we're not using just-in-time ordering? So that's another good way to cut costs. So lots of ways to cut cost. Things like overtime or travelers. If we have a lot of overtime folks, if we have, sorry about that, my husband's sneezing on the other side of the room. If we have a lot of overtime or a lot of traveling staff, like traveling nurses, traveling physicians coming in, working, that can cost a facility a lot of money. So can we avoid those types of costs? So lots of ways to cut costs. It's just a matter of looking at the entire organization and making a determination of where costs can be cut. That's likely the best way. But also then making sure, folks had mentioned coding. Coding is a great way to make sure that medical coding is being done in an accurate way and documentation is being done in an accurate way and this is not, from a compliance perspective, this is an ugly word. We don't like to use this word, but to maximize reimbursement. No compliance officer ever wants to hear that word, but CFOs often like to hear that word. So you never want to code or bill for anything that's not there, but you definitely want to make sure that your coding is accurate and your documentation is accurate based on the services that were provided. So we can use, in this situation, we can use that. We want to maximize the reimbursement based on the services that were provided. So really important to do so. Okay, so let's take a look at the quiz questions. We want to look at the quiz questions. I think I chose 3 based on the top 3 that were missed throughout the quiz so far. I think I have one person that hasn't taken it, so I'll just put up the top 3 of the folks that have taken it. I'm not so concerned at this point. So the quiz questions, the top 3. This first one: provisions under which program reduced payments to hospitals for patients who return to the hospital with certain diagnosed conditions within 30 days of their prior admission for the same condition. So there are 3 main answers: hospital value-based purchasing program, readmission reduction program, and bundled payment projects. And then a combo answer there. Our answer is the readmission reduction program. And what the readmission reduction program is a program where CMS, Center for Medicare and Medicaid Services, put together a program where they were actually reducing payments to hospitals if you had a patient that came to the hospital, was admitted, and then within 30 days of that admission, if they had been discharged, they went home, if they came back within 30 days of that admission, if they came back and were readmitted for the same condition, then there would be a reduced payment to that hospital. And there's actually a bit more to it. It's only for certain conditions, et cetera, et cetera. But it's really aimed at getting hospitals, and as most everyone here knows, I'm sure we've talked about, for those of you that are in the nursing program, I'm sure you know from your clinical work that readmission reduction is a huge aspect of the clinical work that you'll do in your clinical setting, making sure that patients are well prepared to go home and stay home and not come back to the hospital or go to whatever setting it is that they're going to, stay out of the acute care setting, because they don't need to be in the hospital. It's not the best place to recover. It's not you need to recover in a not in the acute care setting. It's easy to become infected. It's convalescing in a different setting is likely the best option, be at home with your family or in a lower level of care like a skilled nursing facility, rehab facility, etc. Being in the acute care hospital setting is not always the best place. But also the problem is that they found that hospitals were not necessarily preparing patients to go home and be successful. So this readmission reduction program was a program where they were encouraging hospitals to prepare patients to go home and be successful at home or in their other settings. So that was the key there. Hospital value-based purchasing program is another similar program where it's about quality. It's about quality of care in the hospital setting, but not specific to readmissions. So it's about providing quality care while the patient is there. And that's what that is mainly about. There's a lot of aspects to it, but the focus is providing quality care in a number of different ways. So that is this answer, readmission reduction program. So our next question, if I can get down to it, there we go. So most providers agree that blank is the best way to be reimbursed. So our answers were capitation, cost, charges, or per diem. So our answer is charges, and of course providers would agree that being paid your charges or a percentage of your charges is the best way to be reimbursed, because you can raise your charges at any time. So I could say, right now, hey, I feel like raising my charges 25% next week, and then the insurance company is going to have to pay that additional payment in, if they're paying me 80% of charges, for example, then my payment from the insurance company will go up. And back in the day, when I first started in this industry 25 years ago, I worked for an insurance company, and our contracts were based on a percent of charges. And years and years ago, that's really the way the commercial insurance industry worked. Everything was pretty much based on a percent of charges, but that's what it was, a percent of charges up to usual, customary, and reasonable price, meaning that there was kind of a ceiling to it. The providers couldn't charge $1 million for an office visit, but it was up to a usual, customary, and reasonable price. But unfortunately for the providers, that realm has kind of gone away, and most providers are paid based on a variety of different things. Typically, providers in the professional practice world, so meaning physicians and that lot, are typically paid based on a fee schedule, meaning that if they bill out a certain service, so maybe an office visit or a surgical service, they're paid based on a fee schedule. So I bill for an appendectomy, and it doesn't matter what my charges are. I could charge $3,000 for that appendectomy, or I could charge $7,000 for that appendectomy, and I'm going to be paid the same amount. It's going to be paid X dollars, $700, whatever it might be. So there's a certain fee schedule, meaning that based on this medical code, this CPT code, which is the type of code, you're going to get a specific fee amount. It's related to that code. So that's just how things work typically. Some providers are paid based on capitation, meaning that they get a certain amount for the patient each month. So that's typically for primary care providers. They get a X dollars per month, and it's called a per member per month fee. That they get paid each month, and that's great for, especially if you have patients that are very well, don't come to see you very often, and that can be a great model for. It tends to work in the HMOs, a really great model, especially if you, like I said, if you have really well patients, they don't see you very often, and you have you run a great wellness program, keeping patients really healthy. Can be a really nice model in your practice. So, but providers like to have to be paid charges, but that's kind of gone by the wayside nowadays. A per diem payment would be X amount per day. So maybe like in the hospital setting, hospitals way back in the day, hospitals would get X amount per day. But again, that's not a common payment mechanism anymore. Okay, this last question, which provisions reduced disproportionate share hospital payments? So disproportionate share hospital payments are a type of payment that comes from the government, and disproportionate share is when a hospital takes a disproportionate share or a large number of patients that are of a low income or uninsured patients, and disproportionate share hospital, or DSH. These are often called dish payments. So if you work in a hospital setting, maybe you've been in meetings, you've heard, you've ever read a newsletter or anything that's come out from your facility, and you've heard them refer to dish payments. That's what these are: disproportionate share hospital payments. So the dish payments really supplement a hospital's income with regard to Medicaid patients, so, or any low-income patients. So we get X amount of dollars from Medicaid, but then there's this extra piece that we don't get paid when we take, we have this much cost and we get this much from Medicaid, but there's this extra piece of the cost for those patients that we don't get paid. But these dish payments that we receive helps to cover that cost. So that's why dish payments are very important to hospitals that see a large volume of low-income patients, be it Medicaid patients or uninsured, the uninsured population as well. So the bundled payment projects, that was out of a lot of the health reform provisions that we've seen over the last several years. The bundled payment projects, and actually now, as I'll talk about in a minute, those have kind of gone away. So it'll be interesting to see how, as that's gone away, how this will be impacted. But the bundled payment project provisions, as those were kind of put in place, it actually had an impact on the disproportionate share hospital payments. So those provisions impacted one another. Now, what's interesting is the bundled payment projects under the Trump administration, they've actually done away with pretty much all of the bundled payment projects. I don't know how many are still left. They've kind of put I think they've just put a hold on them. They haven't done anything to the regulations. They've pretty much just, like I said, put a hold on them. So I'm not sure how that has impacted the dish payments, if it has had any positive impact on the dish payments, or if those have held steady as well. I haven't seen anything specifically that has talked about if there's been a bounce back in those dish payments or if they've held where they were at. So it'd be interesting to see if these bundled payment projects continue to fall off. They were not terribly popular with facilities, so it was a plus for the hospitals to do away with those bundled payment projects. If these dish payments will bounce back, that could be a good help to facilities across the board. So. Okay, so that's our last quiz question. Again, if you have any questions or anything this week, I will be around. I just will not be around in the office in Pittsburgh, and my daytime availability will be limited. So, but please feel free to email as usual, and I'll get back to you as soon as I can. If there is some kind of an emergency, I can't imagine what type of an academic emergency there might be, because I will be on email every day, so it just won't necessarily be right smack dab in the middle of the day. But I'll get back to you as soon as possible. But if there's something that needs to be dealt with within a couple hours, please feel free to email Dr. Wentling. If you email me, you'll get his email back. It is Wentling at rmu.edu. It's WENTLING at rmu.edu. But really, and if you email me, it'll give you an away message and it'll provide that info to you. But really, I will be on every day, and I'm happy to get back to you in the evening or the next morning as well. So have a great week, everybody. I'm going to go to Disney World and celebrate my son's 21st birthday. So hoping to have a great week, and I will see everyone in the discussion boards this week. Okay, thanks so much.